I want to thank our speakers. I want to especially thank our staff. So if all the PCDC staff could just raise your hand so people can know who you are, great. So step around and talk to all of us. I want to particularly thank, well, there you go. I want to particularly thank Jennifer, Jonathan, Anissa, Cynthia, and Jordan for putting this event together. I want to note for everyone that we are videotaping this, not to live stream, but to release at a later time, and we are doing photographs today. So just letting everyone know that's part of what we're doing. And as I said, please join us afterwards for some good food and for conversation. We have this space until about 7:30. So I'm Louise Cohen. I'm the CEO of the Primary Care Development Corporation. We're a not-for-profit organization that provides capital financing, technical assistance, and advocacy to expand primary care access and advance health equity in communities that need it the most. We've always been about primary care. When about 30 years ago, we were founded to specifically address the health equity and racial justice by ensuring access to primary care, particularly in low-income communities and communities of color in New York City, and particularly to address the disparity in capital access by the safety net. Institutions like federally qualified health centers, and I know many of you represent them today, and safety net hospitals. One of our safety net hospitals, Jamaica, is one of our first financings. They're over here. It's really glad to see you. We've been working with you for 30 years. We're glad to work with you. And Callan Lord also is one of our first financings. Just important to note that we've been here, and a lot of the organizations that we financed at the beginning are incredibly robust at this time, and some of that we take pride in being able to help them and help the other organizations that we've worked with along the way. Ultimately, we've invested about $1.7 billion over the last 30 years, and we've worked with thousands of primary care providers and practitioners. We've helped create quality jobs. We've done a lot of technical assistance to support both better outcomes and better business activities. And we also have a policy and advocacy wing, which over the years has led to, we believe, a number of positive changes, particularly in New York State, including, you may not know this, the establishment of a primary care office at the State Department of Health, which we were instrumental in advocating for. And our advocacy work has intensified over the last couple of years. And there is beginning to be what looks to me like a national movement to strengthen primary care. And I'm really proud to both be part of that and to help work with the other people who are working on this across the country and in this room. So one of the things that I think has happened recently is that in 2021, you may be aware that the National Association of Science, Engineering, and Medicine, NASEM, used to be the IOM, released a report about the importance of primary care. And basically they established that primary care should be central to our healthcare system, and that everyone should have a usual source of care. But really importantly, and a concept I hope that we could talk about a little bit tonight, is that primary care is a common good. It should be a common good, like many of the other things that we consider common good: clean air, clean water, good schools, things that we provide to everyone as a matter of course. And while there are islands of excellence in primary care, both in this room, in New York City, state, and across the country, we know that primary care is fragile, and weakening. And there's a number of reasons for that. We're going to talk about it there tonight to try to think about, well, what can we do to shore up primary care? Because we know that something has to be done. Something has to change. And we know that primary care practitioners are asked to do a great deal, but remain the lowest paid of all types of healthcare organizations. We know that primary care improves health, it increases life expectancy, and reduces overall system cost. We want primary care to provide prevention, early diagnosis and treatment, care coordination with other levels of care, treating the whole person, not as a collection of disease entities, and addressing the social drivers of health. And all this for 5 to 7 cents on the healthcare dollar. This is not sustainable. So tonight we're going to be talking with some experts in the field. They're going to share what they've done to create a more primary care-centric healthcare system, some of the other policy things that we can do in this next number of years to do that, and to highlight some of the key policy things that we think are not just, we're going to start with the blue sky, but then we're going to get down to brass tacks. What can we actually do? So you have there bios on your chair. Not going to go through them. They truly are experts in the field. We have with us Commissioner James McDonald from the New York State Department of Health, Acting Insurance Commissioner from Rhode Island, Corey King, and Dr. Joe Bedencourt, who is the president of the Commonwealth Fund, one of the premier organizations nationally that does a lot of work around primary care. In the course of the conversation, we hope that you will think about questions that you want to ask. We have some staff at the side who have cards. We're going to have you write them down, and they'll pass them to the side, so kind of get their eye. If you want to ask a question, we'll take those up here at the end. So I'm going to start with our opening question. Each one of you gets about 5 minutes to answer the question, which is, so while we as PCDC have long asserted that primary care is the foundation of a well-functioning healthcare system and what we believe is a cornerstone of healthy, thriving communities, I would like to ask each of you, from your perspective, why is it critical for primary care to be the central foundation of the healthcare system? And so this is a blue sky conversation, right? So I'm going to start with you, Commissioner McDonald. Why don't you tell us a few things about what you're thinking about?
Yeah, so, thank you, and it's great to be here. And I hope I don't mean to start the conversation with splitting hairs, but it's interesting. We use the word healthcare system a lot. But just to frame the night, we all know we don't have a healthcare system in the United States, right? Like, let's just own that, right? Because you'd be right in saying, gosh, why are we still talking about getting a primary care provider in a civilized country? Like, why are we still talking about that, right? Weren't we talking about this 20 years ago, 30 years ago? So you'd be okay to ask that question. But part of why I'm here tonight is so, most of you don't know me, by the way, so you might be like, how does this guy think, right? So we have a healthcare marketplace, right? So because we have a healthcare marketplace, this is what's going on, right? And I'll frame a little bit about what is one way to define public health, right? So one way to define public health is in public health, we have all the people all the time. So that's my definition of public health that I carry in public with me, right? When I think about my time as a pediatrician, by the way, I saw my last patient as a pediatrician September 9th, 2022, not that long ago. He was a toddler with a diaper rash, in case you're curious. I helped one person at a time. In that case, a toddler get rid of a diaper rash, which was an important thing for that toddler, right? But there's something very important about helping one person at a time. When I think about primary care, though, one of the things I think we started really seeing 20 years ago is we can have subpopulations of patients, right? We call them panels, right? Team-based care, none of this is new. But even when I was working with the Indian Health Service 20 years ago, we were talking about these concepts of why it's so important to have continuity of care, team-based care. And I think one of the things we saw was how do you manage population metrics now? And I think that's really important. Where I really see the future going, though, is where I think in the past we really focused on access to care, which is really important. Getting people to adhere to care, really, really important. Where I really think we need to be in the future is how do we get care outside the exam room to actually complement care inside the exam room? How do we get the social determinants of health to, one, be identified and to be addressed, right? Because it really isn't going to be wonderful for this person to solve their hypertension if they can't get to work because they have no transportation, or if they don't have stable housing, or if their family has no stable neighborhood that they live in, or if the education system for the children doesn't work. So I think really what we're seeing is how do we keep that primary care provider not solving those problems, because I'm not asking the primary care provider to do more than they already do. We already asked them to do too much. I'm not saying, doctor, I need you to do more. It's not my issue at all. It's more like, how do we bring community-based organizations, how do we bring other partners into the healthcare experience? So we're actually addressing, these social determinants of health. And, I'm just going to close out this concept with a little bit of how do I think about things, right? Because one of the things you might be thinking is does the Commissioner of Health have a framework for how he thinks? And it turns out I do, and I'm not that complicated. If you're thinking is this guy, what you see is what you get guy? I am. There's just not a lot of moving parts to Jim, right? So when I look at any policy issue, I ask myself 3 questions. First question is, who gets helped? I always like to know who gets helped, right? Second question is, well, who gets paid? Well, that's really important, right? And the third question is, someone getting somewhere at the expense of someone else? Because I live in a country that's got an issue with systemic racism. We all have implicit bias, so I need to know those things. And by the way, I think the way most of the world works is who gets paid. I got to take care of me first. I'm the public health physician. I'm always with who gets helped, who gets paid, is someone getting care at the expense of someone else. The other 3 questions I asked myself, and I learned these when I worked on the Navajo Reservation, was And I do this a lot inside the department. We're going to start something new. You know, the first question is, well, what is the work? Well, then I ask, well, who should do the work? And then it's like, what's the public health value? And the reason I just give you that little thing is that when I look at what's the work, when you look at what is the work of primary care, there's a lot of work to do in primary care, but when you look at who should do the work, it isn't always the primary care provider. There's other people who can and should do the work. And the value is we'll actually accomplish our goals. Because one of the things I see about New York, by the way, and we'll talk about workforce tonight, I hope in more detail, is we haven't embraced the concept in New York of working at your highest level. We've actually done the opposite. We often insist on the highest credential, but we're fine with you changing table paper in the exam room. We're still doing that. You know, and I think we need to look at other strategies of like, how do we get more aligned with what other states have done, other places have done, with other ideas that make sense, so that the work that the primary care provider is doing is the work the primary care provider should be doing, but surrounding the primary care provider with people who actually can get other work done that actually addresses the care that needs to happen outside the exam room. I'm going to stop there.
Okay, that was a fair amount. We're gonna go to Commissioner King. What do you think? What's your blue sky here?
And it's really a pleasure to be here. Thank you for inviting me, and it's great to serve on such a distinguished panel. So I think you recited the evidence and the value behind primary care as the center of a high-performing, equitable healthcare system. Primary care is the first point of contact for patients, facilitates chronic disease management, and supports a more efficient use of the healthcare dollar. And of course, our healthcare dollars are growing at an extraordinary rate, so we need primary care to really serve that function. I see healthcare purchasing in this country as fragmented, extremely fragmented. It's not a surprise to anyone. It's fragmented between state and federal levels, between public and private payers, and primary care deals with that fragmentation. But again, the evidence basis that you cited, those are public interest objectives that we should pursue. And government has a role in advancing the public interest. So from where I sit as the acting health insurance commissioner in Rhode Island, I look at my laws, the laws that I'm accountable for carrying out. And our statute is very broad. Rhode Island is very unique in the way it organizes oversight of commercial health insurers. Every state has an insurance department, but Rhode Island has an office dedicated specifically to the oversight of commercial health insurance, so we developed a specialization. And the law that enabled our office says that in discharging the powers and duties of office, the health insurance commissioner shall direct insurers towards policies that advance the welfare of the public through overall efficiency, improved healthcare quality, and appropriate access. And as my predecessor, Chris Kohler, liked to say, that's a shall, not a may. So in discharging our powers, we must pursue each of those objectives. That doesn't mean that I have unbridled authority to decree anything I want, but I'm accountable for ensuring that Rhode Islanders can afford health care and that they have access to health care, because health insurance facilitates access to health care. So we have to think functionally what we need to do as a regulator of commercial health insurers to support the delivery system, because, yet again, primary care is the first point of contact for patients, supports chronic disease management, and supports a more efficient use of our healthcare dollar. So I'm happy to speak to some more specific initiatives going on in Rhode Island, but that's how I see it from the perspective of government. It's our responsibility to advance the public interest.
Dr. Bedington, what's your big...
Yeah, it's great to be back here, and I'm from New York City originally. I'd like to borrow one of the Cater shirts because I'm originally from Puerto Rico. So to see Cater say, "From Puerto Rico with love," I come to you from Puerto Rico with love. And just I'm getting a hands up back there. Thank you. I'm going to get one of your shirts, though. So I'm going to speak to this from two perspectives. One, as a practicing primary care doctor today, in a state that many would say is doing quite well around primary care, which is Massachusetts. And then I'm going to speak to you in my newer role last year as president of the Commonwealth Fund. So I last saw patients on Tuesday, about 13 of them. My oldest patient's about 113, Cubana from Boston. My youngest is 18. About 70% of my patients are Spanish speaking. This for me is a calling. It's not a job, it's a calling. While many are trying to leave primary care, I'm trying to hold on because it's so meaningful to me. And that's the way a lot of my colleagues feel. Yet the day-to-day of our work is incredibly challenging, even in a place like Massachusetts. And I'll get to the policy pieces where we do quite well around value-based purchasing. We've invested in accountable care organizations. I mean, we've been at the cutting edge of a lot of the policy things that we're talking about. But nevertheless, still at a place like that, primary care doctors are experiencing a lot of burnout, a lot of demoralization, which isn't just about fatigue. What I like to tell people is, the pandemic was incredibly difficult, but it was also exhilarating because as a primary care doc, you were involved in surge teams and doing things to really save lives in that moment. And so you come off this period of being exhilarated to then dealing with administrative burden, in basket, prior approvals. I think it makes it that much more painful and acute, kind of how this, you're demoralized by being taken away from the stuff that you really love. So the administrative burden, I think, there's not a doctor in our system who doesn't say, if you have a problem that's outside of their specialty, talk to your primary care doctor about that. There's not a form that doesn't get sent to us. All types, from service animal to I'd like a second floor without a carpet because I have asthma. I mean, the list is long. We serve as brokers, really, to address the social needs and social determinants of vulnerable populations as it relates to health equity. And so that's the reality practicing today, even in a state that I would argue from a policy standpoint is probably pretty advanced in a lot of things that we're talking about here. Now, I've had the pleasure of taking the presidency, assuming the presidency of the Commonwealth Fund. We're a 105-year-old foundation who really has cared since day one for those most vulnerable in our healthcare system and invested quite significantly in understanding how we do globally as well as in primary care. And if you look at us as a nation, quickly I'll say that year after year, we spend, compared to other OECD nations, the largest amount of money for healthcare and have the least to show for it. Highest infant mortality, lowest life expectancy, most individuals with chronic disease, and now major affordability challenges with individuals not being able to afford their care even when they have coverage and now driving into medical debt. So that's what we get for our dollar. And when you think about primary care as well, this is not a new crisis. 2005 to 2015, 10% decline in primary care doctors. In the last year, 16,000 doctors have left primary care. And ultimately, we understand the average age of a primary care doctor is 60 years old today. So this crisis is worse and getting worse. So we thankfully helped fund the NASM report that you called out. If you look at the findings and the guidance of that report, HHS just released in early November the way the Department of Health and Human Services is addressing primary care, which we're very pleased about. But it really is about a couple things that we're deeply invested in, which includes the payment piece. How do we think about value-based payment and payment reform? The major caveat is that my colleagues tell me that's nice, but we need to make sure the money gets to where it needs to get to. A lot of my colleagues say, well, we've tinkered with payment reform and different payments, but it never seems to quite get to where the care is. But payment reform with that caveat. The second is we need larger investments in primary care. Yes, we need to all work at the top of our license, but boy, could I use a navigator, community health worker, health coach? These are all interventions that have been proven time in, time out, but we do not fund them through our current healthcare system. So these great innovations end up in the graveyard of great innovation. So investing in primary care, the entire primary care team, is critical. And third, yes, we need to build a workforce. We need to counteract where we're headed, which is a lot of people kind of leaving primary care. And I would argue then the further destabilization of primary care through the corporatization of healthcare that we're seeing, that is, I think, further challenging. I think I'd end by saying that as we think about these policies that we're playing in, we also need to challenge ourselves to not be putting a lot of gas in a car that's not built for the future. I think there are ways to right-size a lot of these things, but we need to have the courage to say, is this kind of going back to the roots of primary care or holding those roots but building out a new future? And I think that's where we'll go with some of these policies.
Yeah, so you all touched on what I think are all the key questions, right? You're talking about payment reform, you're talking about the way primary care is actually organized to do its work, you're talking about the regulatory framework, we're talking about how to build for the future, recognizing technology and all these other things. So I guess I want to move now, and then we're going to have more of a conversation, right, as opposed to all the presentation, but I want to hear what's happening specifically that you think are actual policies that you believe are either currently in place or should be in place in a very next period, in the next 2 to 3 years. Let's really talk, so we sort of have like, that was the big picture of like, where do we want to go? Now let's sort of talk turkey about, well, what can we actually do in this next period? So I'm going to start with you, because in Rhode Island, you were kind of a leader of this starting in 2012 when you really said primary care investment, let's think about this. I believe you were around at the time, although maybe not, you weren't maybe the insurance commissioner at the time, but really has played a leading role in the movement towards thinking about primary care and investing in primary care in a broader sense. So why don't you tell us what policies you've enacted and what you think they've been able to do?
Sure. So I referenced the regulatory framework in Rhode Island as the commercial health insurance regulator who has to view the healthcare system as a comprehensive entity, and again, direct insurers towards policies that address the welfare of the public through efficiency, quality, and access. One of our key tools is our prior approval rate review authority. So we have to review the premiums charged in the individual market and the group insurance markets. As part of that exercise, we look at actuarial analyses of claims trends, administrative charges, and contribution to reserve requests. But the bulk of the premium dollar in 2021, on average, it was 82 cents of the premium dollar was paid out as medical expense. So what are the factors that drive the claims experience that flows into the insurer's rate development that ends up as the premium bill that the employer, the consumer is paying at the end of the day? We started, in terms of grappling with how we fix that, by elevating primary care to the top of the state's policy agenda. It was necessary because we believed that there was an underinvestment in primary care amongst our local payers. The way we chose to address that was through leveraging our rate review authority, which has a public interest criterion within it as well, and to create a set of standards for insurance companies to follow to prove to us that they were undertaking initiatives to improve the affordability of their products. One such initiative would be investing in primary care. So the policy lever that we created was a requirement that insurance companies would increase their expenditures on primary care by 1 percentage point per year above baseline over a 5-year period. To deal with the fragmentation of healthcare purchasing, we created a multi-payer medical home initiative because we wanted to ensure that the investment was going into a new model of care delivery. And at that time, around 2010, the PCMH was all the rage. Now, ACOs are the rage, and there'll be a new rage sometime in the next 5 years. But we created this multi-payer initiative where the commercial payers and Medicaid got together, and then primary care practices would join this initiative and work under a common contract and be paid per member per month payments to support care management and infrastructure at the practice level as they achieved NCQA recognition. And that was one way that we largely dedicated or directed more funding to primary care. There were some modest enhancements to fee schedules, I believe, but outside of the fee-for-service mechanism, we were really emphasizing non-claims-based expenditures. This was also during a time when there really were not any, I would say, good specifications or guidance around what is primary care expenditure. There's been a lot more work that's been done on that in the last 10 years. So that was the initial step. We carried that policy out between 2010 and 2014. In 2015, we modified our affordability standards to maintain primary care investment by commercial payers as we measured it at that time at 10.7% of total medical spending. But again, that's only getting back to fragmentation of purchasing and fragmentation of regulatory oversight. That's only on the fully insured business in Rhode Island. The bulk of your employer-sponsored insurance market is self-insured, which is not within the jurisdiction of a state agency like mine to address. So we have to think of creative ways to create spillover, I think. And there were endeavors by local payers to engage the self-insured community to contribute these per member per month payments and support the care transformation of practices. But it wasn't as expansive, I think, as it otherwise could have been. Since that time, we've also required continuing investment in the patients that are in medical home. And we've moved very heavily into payment reform initiatives. So speaking about value-based payment, we've required commercial insurers to have at least 50% of their total medical payments under an alternative payment model. The way you get to 50% is you use a total cost of care model that relies on patient attribution. It's the payment model that ACOs were built for. That's how you get there. And then the evolution of our requirements for commercial payers, and we try to find alignment as much as we can with Medicaid and Medicare. It's a constant struggle, and maybe CMMI has proposed a model for states that might help address that. But we also are interested in driving capitation in primary care practices to take the revenues that are garnered through the provision of evaluation and management services, office visits, and rebundle that as a prospective payment, capitated payment. We think that would enhance flexibility of clinical practice, provide some revenue predictability, and it should be an enriched model. That was emphasized really around 2017, 2018, and the pandemic hit, and things have been moving a bit slowly since then. I think the point I want to make about all of that is that's a decade of experience of really investing in the transformation of the primary care practice. It proves that states can create these policy levers and pull them. But primary care in Rhode Island is not a primary care nirvana, it's struggling. So this year, I've dedicated a lot of time of the agency to doing a strategic refresh or reevaluation of our approach to primary care. Starting earlier this year, we developed a work plan, what research we were going to review to build the evidence basis, because if you're going to do regulation, you have to have an evidence basis behind it. And we also, more importantly, looked at national and local trends in primary care, workforce, administrative burden, burnout, and we spoke to providers. The two issues that rose to the top of providers' concerns today in Rhode Island are workforce capacity issues and burnout, due in particular to prior authorization and other insurer administrative requirements. So I look at the tools in my toolkit and I say, well, early in the last decade, we pulled that lever of increasing primary care investment and we built a new model of care delivery. I don't think we adequately addressed the fee schedule issue, which gets ultimately to payment rates and ultimately to compensation. We created a culture of collaboration in Rhode Island that we can continue to leverage, but because costs continue to escalate, insurers throw on prior authorizations because that's a one way of making money, right? And the primary care workforce is aging. The providers that I speak to on a regular basis, they were gray-headed when I started at OHIC 10 years ago, and they're still gray-headed, and bless them, but they're going to retire eventually. So we have to think long-term. Where I'm at with the Office of the Health Insurance Commissioner is I'm ready to pull those policy levers again. I think we need to pull the primary care expenditure policy lever again. I think we need to emphasize, in this case, the fee schedule a little more than we did the previous time around. And we've got to reduce the volume of prior authorizations that primary care providers are having to deal with. There have to be regulatory guardrails placed on utilization review in order to effectuate that. So that's just a kind of a broad, I guess, recitation of what we've done in Rhode Island. It has, I think, given us some strengths that we're going to build on. It has not led to perfection, and we have to continue to do the work, but the work can be done.
Yeah, so I think one of the things that we learned about Rhode Island, as I understand it, is that during the course, at least the first 5 years of this process, total cost of care didn't increase, which was always one of the things that we hear. If you made more in primary care, it's all going to cost more. And the second, and so I think that there was, we also saw that I think that you were able to increase the supply of primary care providers at a certain point. Maybe that's capped at this point, but there was at least some motion to say people might be coming into this field because they saw some future in it, and not just the pain points.
Yeah, I mean, there's been a change in the mix of the workforce. There are more advanced practitioners in play now. We were able to bend the cost curve, but we also adopted some concurrent cost containment policies, capping hospital price growth. So one way you can try to limit the overall impact to the consumer is address the big ticket items like hospital price growth, dedicate more resources to primary care, which then should create more efficiencies in managing utilization and service mix if you get the economic incentives right. And we're still working on that. That's payment reform. That's the long-standing task of payment reform that's taken a long time.
I'm glad if either of you have questions or comments, please feel free to jump in. Just one more thing. I mean, I think here, as we listen to people around the country who are thinking about this idea of increasing investment in primary care, whether it is 1% year over year, or whether it is to get to a specific target, however they've thought about it, you know, the question that often comes up from others is, well, you know, then who are you taking the money away from? And so you started talking about it by saying there was a cap on hospital expenditures. Is there any other, would you have any other answer to that question? You know, is this a zero-sum game? Does someone have to lose in order for primary care to win?
You know, you want to be careful when you work in politics not to frame it that way. But again, I think you look at the evidence. So the reason why our healthcare costs are as high as they are in this country is in large part due to the way we structure negotiations through private markets between payers and providers that don't truly have much skin in the game, other than if the insurance company has their premium and they can afford to make the demands of the hospital system met in terms of their pricing, they'll do that, keep them in network. There has to be, in my view, a fair upper bound on the negotiations, because if hospital prices are driving increases in total cost of care and increases in premium, and then we have the inexorable problem of drug prices going up, which states have a very hard time tackling, don't have the policy levers for that, then where are we going to find the money to support primary care? And again, it goes back to having the set of financial incentives across the system, I think, well configured. So if we can organize payments such that the different players, the hospitals, the physicians, have an incentive to manage costs and can gain and earn margin by managing costs, that's something that we should build towards. I think to some extent that is the theory of action that CMMI has in the creation of the new AHEAD model. So we could talk about that later if that's of interest to you.
Do either one of you want to jump in on this? What are things that you're thinking about, policy levers in the next 2-3 years?
I mean, I'll jump in. I think, you know, let me give you an overly simplistic way of how I look at the New York State Department of Health, right? We're one of the largest health departments on the planet, by the way. There's only 7 health departments that have Medicaid that is actually part of their health department. So that's interesting, right? So, you know, the New York State Department of Health is the largest payer in the state by a lot. We're also a large health regulator, hospitals, nursing homes, a few professionals. But we're also this huge public health product line, right? Oh, sure, I have one of the best public health laboratories this planet's ever known, by the way, too, called Wadsworth. But like, it's an overly simplistic way of looking at it, but we're the largest payer. We're a large health regulator, large public health product line. I look at all that, and my job is to align all that so I can eliminate health disparities. This is what I talk about around the department as my vision, right? When I look at things that we can do in the near term, you know, keep in mind, Medicaid, New York City Health, great stuff, moving along, right? But you hear things like 1115 waiver, you hear making care primary, you hear the AHEAD model, and I don't actually like acronyms, so I actually looked up what that means, by the way. And it's funny, like if you actually get around the New York State Department of Leadership table, you'll understand how much I do not like acronyms. And to my plea to anyone on the planet is, let's just use words. So the all payer health equity approaches and development is what that stands for. Really quite a mouthful, right? I really don't know what it is about the federal partners that they need to name everything with something so cute, because it really is a bit of a misnomer. It's all payers if they want to participate. Health equity, assuming we all know what that means, approaches and development means we're going to see what we can do, right? So 8 states are going to be able to get into this, right? 8 states are going to do it. We're seriously thinking about applying to be part of this. The 1115 waiver, which is the Medicaid waiver, we have a waiver in place. We're amending our waiver. I was hoping it would have been done by now. But when you look at the 1115 waiver, it's more money coming to the state of New York in the billions. There's a small state contribution and a larger federal contribution. The thing when I look at the 1115 waiver, as we're finalizing it, more of the money will be focused on health equity regional organizations, independent bodies across state to help identify health equity needs. Social care networks, helping identify needs for people's social determinants of health and how to address that. How to get community-based organizations more involved with this. How to pay primary care practices more like a per member per month payment so that they actually can do some of the stuff to help connect to address social determinants of health. When you look at the all-payer health equity approach and development model, that is going to be something that we would see working for Westchester and downstate. The Making Care Primary would be upstate New York. There's a reason why it was chosen that way. Part of it has to do with the all-payer health equity and development and approaches and development model is you need to be willing to deal with total cost of care, global budgeting, things that are going to be to the advantage of financially distressed hospitals, and that's where we think it would work. For practices that want to participate with that, they'll get a higher per member per month allotment, which could be quite substantial, and would add up quite quickly, but they would need to be in the area where there's a hospital that participates. So these are things that I think are useful. So that's stuff we can do as a payer. I mentioned we're the largest regulator in this state though, right? I don't regulate licensed professionals, but we have to look at workforce very seriously in New York. In New York, we do things differently than other states do. And I think sometimes when you're different, you should say, is our different good? Or is our different making it so we walk uphill when we don't need to? I don't know how many of you play soccer, but if you play soccer uphill, it's a little bit harder, isn't it? I like to play soccer, but I want to play soccer uphill. I feel like I'm playing soccer uphill in New York, right? And here's some of the things where we're different, right? 49 states in this country said it's okay for medical assistants to give a vaccine. Not so in New York. Well, that's interesting, but Commissioner Rose up in the State Education Department and I are friends now. We get along beautifully. We have conversations. We're interested in seeing what we can do about that this year, right? That's just an idea, right? It's interesting. We're the only state that requires a nurse to get a bachelor's degree. Oh, we give them 10 years to do it. Well, why are we doing that? Why do we need to control nurses that way? Because, by the way, we're 46th in the country for passing the nurse certifying license exam in the first attempt, and there's no difference between an associate's nurse and a bachelor's nurse. So I have questions about why we still do that, right? And, over half the states say medication aides can pass meds in a nursing home. I think that's intriguing, isn't it? Because nursing homes are having the staffing challenges, right? And did I mention I was the largest payer in the state? I think I did, right? But you know where I get my money from, by the way? We get it from you, taxpayers. So just saying out loud, my friends, is when I say I'm the largest payer in the state, yeah, I got a $110 billion budget. Half the state budget at the Department of Health is mine, but I get all my money from you. All right, so a couple ideas. When I look at policy ideas, though, remember I said we're a huge public health mission? Here's a couple things we could do in the policy world. We're the first state, near as I can tell, to do a signed commissioner's order for the COVID vaccine. I heard there was a need that some pharmacies couldn't get the COVID vaccine, couldn't get a medical vaccine. My team put a signed order together. That's great. I heard there was the same problem for RSV. We did an RSV signed order from the commissioner. So there's orders from me out there, and every pharmacy now who wants it, that anybody who wants a vaccine for respiratory syncytial virus or for coronavirus 19, they can get the vaccine. I'd be willing to do a signed commissioner's order for every vaccine, to be quite candid with you. And I'm really intrigued by something they did in Rhode Island. One of the things they did in Rhode Island over 2 decades ago, and it's a little easier, by the way, 1.1 million people in Rhode Island. You can actually know 1.1 million people, by the way. And only 4 health insurers, so it's a little bit easier. But they had the idea, the insurers over 2 decades ago said, why don't we just put all of our money we would put for vaccines in a fund and let the health department manage it? We'll just call it a vaccine fund. Why don't you just administer it, health department? And why don't you just make vaccine available for every kid who needs a vaccine? Why don't we just do that because it's a good idea? So Rhode Island did something. There's a reason why Rhode Island is almost always #1 in every vaccine category, because you've removed one of the barriers, which is financial barrier. We have huge barriers in New York, but if I can remove barriers for that, those are policy things that would matter, for example, with vaccine. Oh, there's stuff I can do with women, infants, and children program, make it more accessible. There's other things I can do, but I'm going to cede my time to let Dr. Betancourt have a chance.
I just want to build on that. I mean, we talk about innovation, but what you're talking about is exovation, right? What are the things that are holding people back? You named a bunch that I think was equally as important as being, thinking ahead. I just add, certainly from the role of philanthropy, we have a delivery system reform program led by Corinne Lewis, who's really focused on a couple of the areas that I mentioned. The first is payment reform. I open this by saying the challenges that I face as a primary care doctor. I will clearly say, though, that when we began doing our work in value-based purchasing on the provider side, there's no doubt that we had now registries We have medical assistants working at the top of their license doing vaccines. We have team-based care, chronic care model. So there's been a lot of improvement as we've moved towards alternative care contracts and value-based purchasing. So we're going to continue to drive there. Our role in philanthropy is to generate evidence, create momentum, and move towards change. So we're doing that. And so I believe payment reform is going to be very, very effective. That being said, we need to be thoughtful. We have a real crisis here. You tinker at the margins with payment reform, and you give a slight increase to primary care doctors. Is that going to serve as a strong enough counterbalance for them to say, yeah, you know what? I'd rather spend time with my kids. I'd rather be retired for the marginal amount of payment adjustment that we get. So I just want to be kind of very clear-sighted about what it's going to take when we talk about payment reform to really kind of stem the tide on this crisis. The investment in primary care, the team, right? Because primary care isn't just the doctor. It's really moving towards team-based care, top of license. I think we invest somewhere between 5 and 7% compared to 12 to 14% in other OECD nations in primary care, who do way better than us in a variety of different markers that I opened up with. So yes, I do believe thoughtful investments, building out that team-based care, making sure that primary care providers can do the things at the top of their license and not a lot of things that a team can manage. I think that's going to be really important. And those are two currents, but on the future, yes, we need to do a lot more around building this workforce. Right now, if you're thinking about becoming a doctor, certainly you could go into a much higher paying specialty. Or if you want to go into primary care, you could probably work for a bunch of new startups that, you're going to work 8 to 4 and you're going to be home and, your life's going to be a little bit better. This is what we also need to face as well. So when we think about the workforce, it's not just saying primary care is right, but this is what the future primary care will look like. And this is going to be your role in it. And so I think investments there are going to be critical. And technology is going to play a big role. The electronic health record has been absolutely amazing. I could go into a chart now. I don't have to ask the patient, where have you been, who have you seen? I have it all. By the time I go in to see the patient, I'm able to really delineate to them everything I know. And that creates a huge smile and a huge sense of reassurance. That being said, there is a lot of burden. There's a lot of things that primary care doctors need to manage as part of that record that becomes quite overwhelming. And so our use of potential artificial intelligence, other ways to use technology to decrease administrative burden, I think is promising and something that we'll be looking at as a philanthropy as well. So we want to stay at the cutting edge. We want to be realistic about the future of primary care and understand where we're headed. But those are some of the real anchors, I think, for us.
So let's talk a little bit about, you raised a lot of things. So I'm going to start with payment reform, and then I think we're going to talk about some of those other things in a minute. But so Corey, you said, look, it's really important to make sure that in a payment reform setting, you're actually making sure that that payment reform gets down to the primary care provider. And I know that the corporatization of, big hospital systems eating up a lot of primary care practices has meant that those primary care practices don't necessarily see the benefit of the payment reform. They're staying someplace else. There are certainly ACOs that do shared payments, and that's really in the Medicare program by and large. It's really not a Medicaid program structure by and large. But what we've learned is that the question is, so how do you make sure that in any payment reform, the money's actually going to get to the team? And I want to say it's not just the provider, it's the team. I think that's absolutely right. We have to pay not for services, but for these team-based care and outcomes. So what are the policy things that you can do specifically to ensure that the money actually flows downhill enough to get to the primary care team? We're all looking at you now. Yeah, why don't you start? Like apparently in Rhode Island, you figured some of this out.
So I don't have a foolproof solution on this, but I think there has to be transparency in how the money is flowing between the payer and the provider and then within the provider. And so if you're an accountable care organization and you're taking $1 million of per member per month from a insurance company to fund care management services, if you're doing that centrally and you're supporting the practices that are constituent parts of the ACO, you need to be able to demonstrate to those constituent practices that they're receiving that resource centrally from the organization. If you push that down through to the practices and they take accountability for hiring a care manager, then I think that's a little more straightforward. I've seen in contracts that the per member per months, which will fund other things beyond care management, can be itemized, but I guess it's around shared savings where we lack much insight. So, and that's where when you're measuring primary care expenditures, you encounter a lot of problems. Claims-based payments are easy to track. You know, we have a good mechanisms through doing that through all payer claims databases. We can define primary care at the procedure code and the provider taxonomy level, but it's these non-claims-based payments that account for a material percentage of overall payments to primary care or primary care supports. And for a shared savings payment that is ultimately earned by a hospital-based accountable care organization, how is that then divvied up? So one way we've tried to do that as we build out alternative ways of measuring primary care expenditure in Rhode Island is to just survey the accountable care organizations. There's only a handful, so it's a tractable problem for us, not so much if you're in California, maybe not if you're in New York. But survey them and ask them, tell us what percentage of this would you say you distribute to the docs and how much you retain as a corporate entity. So that's one way I think you could go about doing that.
Any other thoughts?
I think the main way is what you said, which is regulating how much profit you can have at the end of the year. But you have to even go further than that, right? Because people can hide money in salary. You know, it's stunning to me. I don't know if you've noticed it. There's a lot of people who make a lot of money in healthcare, and they're not the people who are generally in primary care. There's a group of physicians who make less than the physicians in primary care. One group, but yeah, it's public health, right? But you know, I mean, we signed up for this, right? So we're okay with that. But I think it gets to the issue of like, it does make you wonder sometimes, you make an 8 digits a year. That's interesting, or 7 digits a year. I don't think most of them in medical school were expecting that. You know, I think some of that gets to sort of a cultural reframing. Be okay with that, you know what I mean? And it's like, it's one of the things I often wonder about. It's like, financially distressed hospital, leadership making 7 or 8 digits a year. Am I okay with that? And I guess it's one of those things where I'm the one asking that question now north of me. Are we okay with that? Because it seems to me that those are some of the questions we'd be asking, because it creates an appearance, you know. But I think when it comes to managed care, limiting how much profit, because it's something you can limit.
I think we're at a unique time here, because I think for a long time, patients, people, consumers weren't very sympathetic to doctors, period, right? And it's fair. I mean, professionals, well compensated. That being said, as more of this has come to the fore, as you've seen the challenges, even among people who are insured, being able to, primary care doctor wait times 3 to 4 months. I see patients, when I see them, the amount of confusion, the amount of frustration, the amount of just uncertainty, not to mention when we think about healthcare costs, the primary care office becomes a battleground for all the direct-to-consumer advertising, new medications that come in. So I'm needing to say, yeah, that Ozempic's good, but it's not for you. And by the way, even if I prescribe it, I'm gonna have to do a PA, and that's not gonna be paid for. But now that just took 10 minutes. So this is like, there's a lot more brokering going on inside that visit, above and beyond just the care, and it's challenging. But my point is that I think we're getting to a groundswell of energy here, and I think even on Capitol Hill, you hear bipartisan interest in primary care and access to care. What's happening? So that's unique, I think, and important. I do believe the transparency piece is going to be critical here, making sure those resources get to the right place, and also the accountability, making sure that we're getting what we pay for. It's not because there's a shortage of money, as we've said here. The resources are there. It's how they're apportioned, and so kind of right-sizing that is going to be important. But we need to move with speed. I guess I'll end by saying, look, there are a lot of things in primary care right now that people will want to, generationally and otherwise, want to do via virtual care. They will want to walk just 2 blocks as opposed to calling us. I get that. And I think we should be prepared for that. That being said, we need to make sure that this evolution isn't a cherry-picking, lemmy-dropping that leaves primary care doctors managing the most difficult, socially challenged individuals with multiple comorbid conditions in a system that is completely underfunded. That is really perilous. So I think we can get a blended strategy here. Primary care doctors are fine, willing to give up some of these smaller things. The challenge is many primary care doctors weren't willing to give up those smaller things because they help pay the bill. So you kind of case mix a couple of colds with some diabetes. we're happy to have that taken off our plate, but then compensate primary care providers for the complex issues that we have to manage on a day-to-day basis. That, to me, is where we're going to head with the new primary care system. And I think technology, payment reform, investments, workforce are all going to be kind of the multi-legged stool that's going to hold us up in the future.
One of the things that I think there's been a lot of conversation about in the last 5-6 years is how, in the new payment reform and in value-based care, primary care providers should take both upside risk and downside risk. They should be accountable for things. And so I think one of the things about the Nason report is basically they said, downside risk may not be something that primary care providers should get. Maybe hospitals should have downside risk, maybe specialists should have downside risk, but why are we asking primary care providers to have downside risk? So I wonder if any of you have thoughts about that, because as we talk about payment reform, sort of value-based care, and this idea that, you need some skin in the game, and you need to, why shouldn't we take money away from you if you haven't done these 5 things? I think you've all talked eloquently about the amount of time and energy and effort it takes to actually be a primary care provider. What do you think about that as a matter of policy? Did you want to start?
I think downside risk is hard for primary care, and I'm not sure. I don't think it's the right place to put downside risk. I think, quite frankly, I think you have to look at primary care is really affordable. I'm interested in just making sure primary care thrives. I'd like to see it as universal as possible. When you look at the making care primary model, that there's 3 levels to jump in at.
Right. By the way, that's a Medicare model for those people who don't know that,
right?
And the AHEAD model, which I can't remember what it actually stands for.
The AHEAD
so
model is all payer, health equity, approaches and development, right? If you leave with nothing else tonight, you leave with, gosh, the commissioner doesn't like acronyms, right? Use words, my friends. We'll all understand more each other. But I think when you look at making care primary model, that we're one of 8 states selected for that, there's 3 levels you can jump in at, kind of a beginner, intermediate, or you really think you know what you're doing. And the financial risk will help you there. But it really is one of those things where different organizations are at different places for that. And I think things like that is like, you've got the infrastructure to do that. And it's not so much about managing downside risk, it's about you might get more financial reward for getting better population outcomes. And I think that's what I'm better interested in incentivizing, right? Like, I'm less interested in primary care practices taking downside risk. More interested in is if you can get your population of people to get healthier, then you can reap a better financial reward. It's funny, when I was with the Indian Health Service, we actually had something similar. We had what were called Government Performance Review Act indicators, and we weren't paid more with that, but it was sort of this thing where you were expected to meet these indicators. We were looking back 20 years ago, and what's the number of patients who have a hemoglobin A1C below 7? What's the number of people who've had hemoglobin A1C? How many people do you have with a BMI? How many do you have to be? These are things that were 20 years ago we were talking about and actually measuring. But these are things where it's like, my goodness, I'd much rather pay people to get populations healthy, because the way you get populations healthy isn't by putting more people in exam rooms, as important as that is, but it's getting the work done outside the exam room. And some of it gets to advocacy work too, by the way. Like, we have a big oral health problem in New York, and you might think, how's oral health connect to primary care? Well, you know what? It's really hard to have an apple a day to keep the doctor away without teeth. I get 600 million teeth in this state, and I worry about all of them, because I don't have enough dentists to do all that work, And this is where it's like, help me with water fluoridation in your community. Can you help me when I'm trying to expand who can actually look at your teeth, by the way? Because we're a state that pretty much says the only people who look at your teeth are your dentist. I don't know. Other states have said dental hygienists can be independent in some settings. I think that's intriguing. Other states are looking at dental therapists, kind of a PA for dentists. I think that's kind of interesting too. And I think we need to be looking at things like, how do you incentivize some of this other work? Because what I'm really interested in doing is getting a population to be healthy. And this is where public health and primary care providers are very similar. Mm-hmm. And quite frankly, one of the things I find about primary care in particular, if you find a frustrated primary care provider, just give them a little bit of work to do that doesn't involve patients but taking care of a population. I think you make their attitude much better, and they get much happier, and they start taking care of the population, they get much happier about that. Those are a few thoughts.
When I think about skin in the game, really it's about accountability, right? You're accountable for a certain outcome. And there's no doubt that fee-for-service quantity versus quality is where we should be, right? I mean, this mill of just kind of, so that doesn't make sense. So value and skin in the game, I think wanting outcomes makes a lot of sense. I do think there's certain places where we can hold a higher bar for accountability, and those are areas kind of where we have more control. So if you think about the patient safety movement, that accountability has, We look at post-surgical infections, but we have a whole team managing that. You have somebody who's in, if it's an ortho surgery, you have physical therapists coming in, somebody's looking at the wound. We're looking at wound infections, a lot of system-based strategies that we've used to do incredibly well around patient safety. There are a lot of things that we can control there in our environment. So I'm just using that as an example. A lot of primary care is public health. And so in so much as we underinvest in our social safety net and the social drivers, when we know that it's debated, but some large number of a person's health is due to, not their genetic code, but their zip code, not, how much meds they got, but, where they live and what their environment's like. In primary care, you're on the hook for a lot of that. So you're taking care of a diabetic, and I do everything by the guidelines, but they go to a community where there's, it's no sidewalks or there's no gyms, so they don't have time to go to a gym, or they don't really understand exercise, or there's no fresh fruits and vegetables, and if they do exist, they cost more and they're less fresh. We are swimming upstream. So to hold kind of primary care doctors in the primary care system completely accountable, I would say take some of those resources and partner them with the public health infrastructure that really helps address those social drivers. And then maybe think about a different set of accountabilities. But I do believe, the clinician or the primary care team being solely held accountable for a lot of things, quite frankly, and I'm not excusing myself, I'm just saying that's a reality that we face. I don't think that's good policy.
I'll just chime in on this point as well. We see risk-based contracting as an important tactic in Rhode Island. I think there's some limited global capitation occurring on the Medicare Advantage side. In the commercial market, it's all fee-for-service based, retrospectively reconciled. The way ACOs are paid is a very sophisticated, glorified pay-for-performance model, right? That's what it is, where you're being paid in terms of your performance on costs. Something I would encourage you to do if you ever have the parameters of a contract, the attributed population, the budget, the risk sharing rate, the minimum loss rate, the risk exposure cap, is just calculate what the worst case scenario is and see if that resulting quantity, which is not going to be the actual loss in all probability, is a value sufficient to motivate change in care delivery. So that's one thing you should do, just to gauge whether the actual risk-based contract on its face is something that you think would be motivating. The way we've looked at this at OHIC when we require commercial payers have risk-based contracts is to structure the risk differently for hospital-based ACOs and primary care-led ACOs. So primary care-led ACOs, which were relatively more successful under the Medicare Shared Savings Program, have a really strong incentive to manage costs because the savings, the profit they earn, is just foregone revenue from the hospitals. If you're a hospital-based ACO and your primary care does really well and you generate shared savings, you're kind of shooting yourself in the foot on the hospital side, right? So that's where we think that you need to have some total cost of care downside risk for the hospital-based ACOs. And then for the primary care ACOs, it would be more of a revenue to primary care-based downside risk that's actually fairly minimal. And I'm not even sure that you need downside risk for a primary care-driven ACO. Maybe the incentive to just earn shared savings by keeping care out of the facilities is sufficient.
Talk a little bit now about sort of whole person care, and then I want to move on to sort of health equity, because I think they all tie together, and health equity is kind of the way I think that you sort of really sort of can sum it all up. But in terms of thinking about whole person care, one of the things that's a conundrum that I think is generated to a certain extent through the public health system, from my experience, is that there's a lot of programs. So we know, for example, in New York State, about 10% of the whole population has diabetes. We know in some counties it's up to 30-40%. We know that about 30% of New York State adults have hypertension. But money comes in very categorically, because the person walks in and they've got diabetes, they've got hypertension, whatever else they've got. But if you're only sort of like funded through the diabetes program, you can only do these things. And if you're only funded through the hypertension program, you can only do these things. And then there are many other categorical fundings, whether it's HIV or all kinds of things like that. And one of the things that from a primary care provider's perspective is it's really hard to manage all of that. I've got this grant that does this thing for these very specific people. I've got this other grant that does this thing for these other people, or I've got this reimbursement, or I've got a value-based payment that's going to be, come to my way if I get this one thing done. So is there any way that you all think about how we can really get to that more whole person care, which was kind of one of the thoughts behind primary care medical home, patient-centered medical home, was to say the person walks in, they've got everything they've got. And I have to manage maybe my funding sources, but really I want to address the issues of that person as a whole. Are there any things that we can do from a policy perspective to reduce that it's a different kind of funding fragmentation, if you will, right? It's categorical money that comes in all over the place, a huge amount. I know it's really an issue for federally qualified health centers. They get a lot of separate funding, they're all not in their heads there, like every single one of them. It's very complicated to do that. Is there any thoughts about policy changes, initiatives, levers that you can pull to sort of think more about integrated care, whether it's behavioral health or whether it's oral health or whether it's HIV or diabetes or hypertension? How do you think about that?
Well, I'll start with what I talked. I mean, if you get to global budgeting, total cost of care, that's really one way to do it, right? Hospital system, here's a big pot of money. You have a year. Next year we'll talk some more, right? But if you get to total cost of care, that's an interesting question. And then what do you really incentivize in the hospital to do, though, right? How many bypass surgeries do I need them to do? Or am I really interested in, like, you get to keep what you don't spend, right? And I think that gets to these large issues of, like, other states are looking at total cost of care. Like when you look at the Maryland, Pennsylvania, Vermont looking at total cost of care, people are entering the all-payer health equity approaches and development model are going to be looking at total cost of care. I think it does raise those questions. And I think it's a really interesting place to be because really what you're trying to incentivize is wholeness and wellness, right? In other words, what we look at now, we've been talking about this for decades here, is how many people did you see, how many RVs did you generate? Oh, you did so well, here's your bonus at the end of the year. That's the model I'm used to, by the way. I did well, by the way, because who wouldn't want to see me, right? And that's one of those things where, guess what? A lot of people like that model. But it's really a shift. It's interesting. I have talked about, we don't have a healthcare system, we have a healthcare marketplace. I've worked in healthcare systems. I worked in the Indian Health Service, which is a healthcare system, and I worked in the military health system, which is a health system. And what's interesting about health systems is everybody's incentivized just to do what's best for the population. Because in the military, I didn't get paid more if I saw more patients. Same with the Indian Health Service. What I got at the end of the day was a warm, fuzzy feeling saying, did a good job, population's getting better, feeling good, And I think those are interesting mindsets, but that really transcends to a different way of looking at healthcare, period. And there's ways to financially reward people in healthcare systems that are different. I'm not sure if we're ready for that, but I think we're so focused on E&M, CPT, and ICD-10 that we're not focusing on what are we trying to accomplish with a really whole, well person in the end.
There's a lot of tension here. I mean, we want accountability, right? So you want those numbers in some particular areas. And at the end of the day, we understand that there is complexity to all this. And a lot of when the whole term population health emerged in the healthcare space, public health practitioners would look at this and say, well, you're defining population as a population of individuals with heart failure, a population of individuals with diabetes. And then you have to execute on these metrics. So you're actually breaking people apart. I think it was a well-intentioned approach to try to take the 20/80 rule, these conditions where, hypertension, major issue, heart failure, diabetes, asthma, the things that are part of that 20/80 rule, and kind of put some metrics around them. But they do run at counters from common sense. Right? So we have, in the early days of care management, we had a diabetes care manager, an asthma care manager, and then we had a care manager for heart failure. And then over several years, said, let's think about a care manager who actually is skilled and multilingual, by the way, and culturally competent to meet the needs of an individual with any one of those five. Because you know what? The majority of patients I see don't come with just one. They come with three. They come with lipids, diabetes, hypertension, at a minimum, and then you add in a couple things. So I do think that that breaking apart creates silos, and you lose the economies of scale, those resources, to manage people at the whole.
So I want to just move, and I just want to remind everyone, if you have a question, flag the people who were at one point standing around, and we have some cards. We're going to take those in just a minute or two. So any questions, please do that. But I want to talk about health equity for a minute, because we know that one extra primary care provider for 10,000 people has 5.5% fewer hospital visits, 11% fewer emergency department visits, 7% fewer surgeries. And a recent article pointed out that one additional Black physician in a community meant that Black people in that community had a greater life expectancy as well as did others, and that there was a reduction in disparity of life expectancy. That's a stunning finding. And so I'm interested particularly, I mean, I know Commissioner McDonald, you regulate you have the biggest Medicaid program maybe in the country outside of maybe California, which is obviously thinking about health equity. I'm wondering how you all think, what you think are the key policy levers around health equity. So we want to go further than studying disparities, right? We know that disparities exist. I mean, that was one of the interesting outcomes of the COVID pandemic, right? Is everyone figured out the thing that we all had known for so many years, right? Everyone in this room knew this, right? And all of a sudden, everyone was like, oh my goodness, there's disparities. Who knew this? Like, maybe we should pay attention to it. So, but from a policy perspective, what do you think are the key things that we should be really thinking about and implementing, the policy levers around health equity? And I'm talking about health equity in all of its, sort of broad perspective.
There's a lot there in that question. Let me start with one though. It costs way too much money to become a doctor. It's just, if you're leaving medical school owing $400,000 or $500,000 worth of debt, I don't know how many people can afford to go in primary care. So I think that's a challenge. It's interesting. Like Tuesday, we did a press conference in Buffalo with the Associated Medical Schools of New York. The governor authorized $4.64 million last year in the budget to help students, we help over 750 students a year of people of color, quite frankly, get into medical school, get through medical school, pay for medical school. I think investments like that are wonderful. Like the number you quoted, when you have a Black physician in a community, how big a difference it makes. I think more investments like that that's just an example of how health equity needs to change though. But I think it's stunning to me how expensive medical school is, period. In New York, a SUNY school is $45,000 a year for tuition. That's a lot. But most of the other schools are twice that. That's still a ton. I think it gets to these other things, so like, well, who can we involve though in primary care? In New York, getting back to scope of practice a little bit, it's interesting how much we control physician assistants. We are more controlling of PAs than other states are. We still have ratios of how much they can be supervised, and I'm not used to that, and I'm used to more of a collaboration model. In New York, we still think PAs need to have a doctor's name on their prescription for controlled substance. We still won't let PAs write durable medical equipment. But these things matter from a health equity point of view, because if I have an area where a physician supervising a cadre of PAs and there's no one else to supervise and that physician retires, I just created this huge area with no physician coverage. And this is not hypothetical problems I'm dealing with. This is real stuff I have to address. And this gets to these other issues, but there's other good things we're doing in New York. I mean, one of the things we're doing that starts January 1st, 24, there's two things I'll mention really quickly. One is adverse childhood experiences screening, ACEs screening. We're the second state to actually pay people $29 to screen for these adverse childhood experiences. The thing is, if you can identify toxic stress in a child, you're more likely to do things about it. And oh, by the way, with the way payments going in the future, we're actually incentivizing you to do things about that. The other thing that's kind of interesting is, this year, I don't know how many, it's a little over $1 billion we're putting towards community health workers to help people who are pregnant in particular. These are nice things that we came out of last year's budget with. I didn't get everything I wanted out of last year's budget, but I got a lot that was really positive. And so those are some tangible examples of how you address health equity. I mean, I worry about maternal mortality in New York too. I'm glad we got the dual thing across the finish line too. And I think space like this where we're actually looking at how do I get care to occur outside the exam room that is meaningful for people so we prevent adverse outcomes. These are a few things about health equity. And just so when I talk about health equity, I sometimes worry that we don't all know what we're talking about. But when I talk about health equity, New York defined it, by the way. If you look up Article 2F in the New York State Health Law, it defines health equity. And it's a wonderful definition. But I define health equity as just meeting people's needs where they are. And it's all people, not just the people we're used to helping. It's an easy way to remember health equity. If you do that, you're doing pretty well.
I know that you've thought a lot about this.
Yeah, so I spent over 20 years doing work in this space, and I'm pleased that the pandemic happened, that our national reckoning on racism happened. That's great. A lot of people got religion on health equity, and we're pleased about that. But there's me, and I stand on the shoulders of many, many people who've been doing this work over generations. People like Jack Geiger, who was a mentor, and Michael Bird, and others who were really important to me. So I think, I think it's always important to call out that this is a journey. I think that there is no one suspect and no one solution. My career has been focused particularly on racial and ethnic disparities in healthcare and the services that people receive, with the full understanding that the significant disparities, differences in health outcomes that we see by race and ethnicity in this country are predominantly driven by the social drivers of health, next driven by access to care, and third driven by the different quality of care people receive in the healthcare system. There's the same amount in the last few years of black men in medical school as there were in the 1970s. If we look at just the workforce issues, minorities remain incredibly underrepresented in the healthcare workforce. Now, we don't think, provider of color is the silver bullet, but it is certainly a large part of the solution. The simple fact that I can speak Spanish to a patient and have a similar lived experience and cultural understanding, I think, does provide more yield. At least I could do the visit quicker and I could do it more efficiently, and there's a sense of connection, trust, satisfaction. So that's real, and we need to be real about that. And so I do think that investments in diversifying the healthcare workforce will help us address some of these health equity challenges. I'd say, second, it is about systems of care. For all too long, we've built systems and strategies that fundamentally have not been constructed to meet the needs of anywhere from anywhere at any time. They have been targeting, I think, individuals with a high level of health literacy, mobility, digital literacy, and the list goes on and on. Until we have the courage to really have that equity discernment in everything we do in the healthcare system to say, okay, how is this going to impact these 10 patients, and we'll lay out these categories. And by the way, acknowledge that the challenges that minority patients face are not unique to them. Those are shared in different ways among different populations. I think that will go a long way in addressing some of the disparities we see. But after doing this for some 20 some odd years, I guess I'm left feeling like a lot of our progress has been drip, 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 early adopters. It has never been at scale. And as I mentioned, a lot of things that foundations like ours and others fund that end up showing great outcomes, but they're not built into the financing, our healthcare financing system. It really is about two things: financing and regulation. What we've seen in patient safety, bringing that back in as an example, I think we've seen incredible advances because we've put carrots and sticks in place that are legitimate. And I think we're finally starting to see pay for equity, payment reform with a particular focus on equity. CMS is coming out with some standards, Joint Commission, NCQA. So I think we're ramping up that space. But this isn't rocket science. It's about investment and holding people accountable. And that's something we've not done. And I think that's what we need to do. And people will challenge us to nibble around the edges and give us 10 reasons why we can't do it. We can do it. And we need to build that political will to do it. And so that's the way I think about health equity, certainly.
I think one of the things that we've learned in our consulting work, certainly, is that a lot of providers, whether they're FQHCs or whether they're independent practices or hospital outpatient, which I think is important because we're talking about the whole ecosystem here, not just like one component of it. A lot of them, when we've worked with them around patient-centered medical home recognition, for the first time, they're looking at their data and saying, oh, this is a disparity that I see among my own patients here, and trying to address that. I mean, I do think that, you can sort of talk about it big picture, but you can also talk about it at the practice level and say, like, actually, what am I seeing in my patient population as well?
If I could just say one quick thing, I mean, there was this big approach to say we need to integrate this into primary care, primary care. I screen for domestic violence, gun safety, housing insecurity, food insecurity. I mean, there's only so much that the primary care system could do without building that investment. So yes, I think we're all in for that. But the amount of things that we're trying to integrate into primary care, it's untenable. And that's what we're experiencing on a day-to-day basis.
Yeah, so there were a number of questions from the audience about sort of, are you only talking about private practices? Are you really talking about federally qualified health centers? Are you talking about hospital ambulatory? Are you talking about sort of the different models? Like, how do you see those sort of components of the healthcare system relative to primary care really being strengthened over the next, say, 2 to 3 years? I think that's really the question. So you're really focused on the commercial payers, but they do pay mostly, probably not as much FQHCs as primary care providers in an independent practice or hospital outpatient departments, right? Probably. But Medicaid really pays for a lot of, sort of all those three. And then I think from a policy perspective, how do you see those? Do you see that there should be 3 different kinds of payment structures? Do you think there should be one payment structure? How do you think about promoting the entirety of the healthcare ecosystem and not only one component of it? Because if you could fix this, then we can all go home in 5 minutes and then like, I'm done.
It's interesting, like, you talk about funding federally qualified health centers a certain way. It's interesting, like, when you look at where you see making care primary going and where you see future payment going, you're actually trying to be close to getting people to function like federally qualified health centers, right? Like, in a federally qualified health center, it's normal under one roof to have primary care, dental care, mental health care under one roof. That's normal for a federally qualified health center. It's normal at a federally qualified health center to help people get health insurance, help solve their transportation. These things are normal to be part of the community, and I really think that there's a lot you can learn from a federally qualified health center. And so I don't know that I need changing of federally qualified health centers. I think when you look at incentivizing practices to be more like federally qualified health centers, that's to me more valuable. This is something I've just seen in my own experience, is that there's a reason why federally qualified health centers work better in communities, so I'm a big fan of them. And I think that we could learn a lot from how to do that.
Yeah, so FQHCs in Rhode Island have a different payment model than private practice or hospital-based clinics. I look at it as having payment levels sufficient to create compensation sufficient to attract and retain the workforce, and also thinking of ways to create payment models that enhance or maximize flexibility within clinical practice and support quality. I think that's kind of the general frame that I would bring to that.
If we're going to be equitable, we really pay FQHCs more, in my view, than anyone. I mean, if you talk about
I'll throw them in, they'd be happy.
a couple of my friends, I invited them, thank you. All kidding aside, I mean, let's be real. I mean, you think about the complexity of a primary care visit in a health center versus an academic center versus a private practice. I mean, the concentration of those social drivers, the concentration of chronic disease. I mean, all these social drivers really come to root, in communities that we well know. And the FQHCs there are doing, and they're doing God's work. So if we're really thinking about an equitable way of doing this, we would compensate by complexity, and I would argue that FQHCs would probably be compensated the most. And then we think about it that way. Again, this is a pie in the sky, but we need to understand that yes, Medicaid rates in different states really drive very, very different outcomes for different populations, particularly vulnerable populations, and they vary widely. And I lived it in my clinical life, and I've seen very different approaches, and that's a reality. And so I do think it's a challenging issue. And do they get treated differently? I'd say applying a lens that is about that complexity and those needs. I think that is 2080. That is where you're going to get your biggest return on your investment from a public health standpoint.
So there were a couple of questions that were very specific to some things that I think maybe you can speak to the commissioner or his staff about in terms of why is making care primary only downstate versus upstate. I don't think we have the time to talk about that. It's obviously a lot of people are very interested in that. I want to ask you one more question, and I'm going to do a quick lightning round. But I think there was an important question here about how do we think about the people who actually aren't getting into care? Like we only deal with the fact that like fee for service right pays for the people who come in the door. But if we actually want to deal with population health, we actually have to deal with the people who aren't walking in the door. So what are we doing about that, and how can primary care reach out to those people or be part of the solution for the people who aren't getting the care that they need? And we know that a huge proportion of people in this country don't have a usual source of care.
I mean, I think the numbers in New York are concerning, right? If I read what I read, it's accurate. 3 out of 10 adults don't have a usual source of care, which concerns me, and 18% of kids don't have a usual source of care. That concerns me too. Another group that concerns me a lot is people who are in my country who don't happen to be documented, because as a physician, I'm very interested in their health and very interested in making them feel welcome, but without insurance, you don't always feel welcome. When I have people who come to the country as asylum seekers who are documented, we can offer them an essential plan. I don't have a lot to offer folks who are undocumented. That's a difficult question. That really is a national question. It's kind of unfair to put that on a state in particular to solve that issue, but I think that's one of those issues is how do you make everybody feel welcome? I was intrigued recently, NYC Health is an interesting program that Health in Hospitals did, to make primary care available to everybody. I think it's very intriguing. And because I think how you make people come in who haven't come in is, one, give them access. If you don't have health insurance, if you don't have health insurance, it's clear you're not welcome. I think that's just a really important thing to minimize our uninsured population. We're working on that as we do the unwind. I think the other issue though is getting access to people where they want the care. You know, one of the things I saw when I worked in health services, if you wouldn't come to us, sometimes we would go to you. And that's a really intriguing approach as well, but when you're not paid per person necessarily, you know, the public health nurse getting in a Jeep going on the dirt roads isn't a bad idea at all. Quite frankly, it was something we did. We had more public health nurses than a lot of other, because when you don't, you know, when you're interested in population health, it's amazing what you fund. You know, one of the things that I loved about Indian Health Service, by the way, is under one roof, you not just had primary care, subspecialty care, dental care, mental health care, inpatient care. You also had this huge thing called a health department all under one roof, and you even had a couple traditional healers. It was really quite a blend that worked pretty well. So,
I wish I knew this question was coming because I would have brought a statistic. But there's a material percentage of members in Rhode Island, commercially insured members, that are not attributed, and attribution occurs either through a retrospective analysis of claims and patterns of visits, or through PCP designation if you're in an HMO type product. And I kind of wonder if everyone who should be accessing primary care did, what kind of workforce would we actually need to accommodate that demand? Because to some extent the supply is not so well calibrated currently to the demand that exists, but if everyone received their office visit every year, like I did this past Monday, what would that mean?
I'd just say the pandemic was incredibly difficult, but boy, in terms of getting things done, the speed, we were working the pandemic and we'd laugh and say, do you remember in old times, we'd schedule this meeting for 2 weeks from now, and now like we're getting it done. And it was fascinating, it was exhilarating, and so many innovations came out of that. And you know, many of us did a lot of mobile work, right? Where we, not only did we have our health centers, but we went out and mobile. And you know, I think it is that type of creativity. I also lament the fact that when we think about digital, really it's, you know, communities that I would argue would get the biggest return on investment from kind of digital and virtual and empowering them up with those capacities are the communities that, you know, are they're least tested with them. By that I mean companies don't invest in kind of, you know, leveraging them in those communities that are least able to get them. You know, we have remote monitors now for diabetes that are incredible. I have patients who come in and track their sugar. The patients who need it the most can't afford it. You know, so it's this affordability and kind of this notion of how do we make sure that these innovations, which can be very important, including mobile and others, are really scalable to the populations who need them most. That I think is a question that we continue to ask and drive towards.
So we've just our last question here. I mean, we've talked a lot about a lot of things, some of which require funds, some of which can be rebalanced through other ways. But one of the sort of controversies across the country at this point is, you know, do we think that when we think about the 5 to 7 cents that primary care currently gets to do all those things that all of you think are so important, do you think that setting a state or a national target for the amount of money, you referenced the OECD countries, about 12 to 14%, and oh, by the way, they spend a lot more in social services, so that's really important to mention. Do we think that, do you, either of you, and this is sort of a yes or no quick lightning round question, do you think that setting a target at the national or the state level is actually one of the strategies, not the only one, but a strategy that would be supportive of getting us to where we need to go? So I'm going to start with Corey, because I think you all have somewhat answered that question, but I don't know, retrospectively, looking back at Rhode Island, do you think that was a good strategy? So this is more like, you know, quick answer, not a
yes. I think that we've been perhaps overly focused on the percentage of primary care spend as a percentage of total medical spending. We should also look at per member per month. You know, primary care spend is another metric to evaluate. And then finally, just on, I'm going to use the phrase ahead because I don't want to say the whole thing. The acronym. So one of the components of the ahead model that I think is quite attractive is because of the fragmentation of healthcare purchasing. It is holding states accountable for meeting an all-payer primary care investment target. We don't have an all-payer primary care investment target in Rhode Island. We have a fully insured commercial primary care investment target in Rhode Island, and I think that would be an innovation worth pursuing.
Either one of you want to take that one?
Sure, it's a great thing to measure, and I think you measure it and you look at it like you do with every other measurement. What does it mean? Yeah, of course you should measure it.
I think yes, you want to set it, but more is not better. We spend the most money, right, in general compared to other nations, but it needs to be more and smarter. But I do think we absolutely need to set a target to do better here and do better in a balanced way.
All right, well, thank you. I really want to thank you for this. I mean, I feel like we've heard a lot of very specifics, sort of some blue sky and some thoughts about where we could go in this next period, which I feel like was very useful. But as they say on Wait, Wait, Don't Tell Me, if any of those things come to pass, you'll hear about it first at PCDC. And I want to thank all of you. I really want to thank Dr. Betancourt, Commissioner McDonald, and Commissioner King for coming and participating in this conversation. We have food, we have drink, we have good conversation. For those of you who can stay, we really appreciate your being here tonight, and we think this is really just the beginning of a conversation. This is certainly not the end of the conversation. Thank all of you for coming.